Acha, Assalamu alaikum, everyone. I just want to thank all the organizers for giving me this opportunity. I think of all the talks that you have heard this morning, this is going to be the most interesting one because it has all the data that you ever wanted to know. So these are my disclosures. So the talk that was given to me was latest ACC guidelines, which came out for revascularization in 2021, and then there was a slight update in 2022. But I thought just to get a general consensus and to keep things simple and also to sort of feel how much homogeneous both these European and ACC guidelines are, I've just taken a few slides out of the ESC guidelines and then tried to show it's not actually very complex if you want to follow the guideline-based management of complex coronary artery disease. So just going over the 2018 ESC guidelines, these are the latest guidelines by ESC. Procedural aspects. So what were the upgrades? What were the downgrades? So what they have said is class 1A indication, use radial access as much as possible, and then drug-eluting stents for every PCI. A DK crash sort of has been added to the ESC guidelines. We all know that the European Bifurcation Club always advocates provisional and TAP and everything, but DK crash has been added to the ESC guidelines. What has been downgraded is routine revascularization of the non-culprit lesions during primary PCI. And then use of bioabsorbable scaffolds, which we can talk about. That's in a different lecture. The other downgrade from class 1 to class 2A was routine use of our protection devices for our vein graft interventions, whereas it was always considered a class 1A, but it's now been downgraded to class 2A. So upgrade is OCT for stent optimization, and then for all bifurcation lesions from a previous classification of class 2A, we have upgraded provisional stenting to class 1. But again, DK crash has at least been added to the guidelines. Anti-thrombotic therapy. So we don't use cangrelor in Pakistan. It's pretty commonly used in US, but again, it has a lot of insurance issues. It's not a very cheap drug, so you have to really justify to insurance why you're doing it. Mostly used practically in patients who come in unconscious in cardiogenic shock and stuff, where you can't really predict if the NG tube driven oral antiplatelet therapy is going to do its job. So cangrelor is used there, and then something that we don't use again in Pakistan, that's de-escalation of your P2Y12 inhibitors. These are all your ticagrelors and stuff. So we would very commonly do a PRU, platelet reactivity unit, on these patients. And if these patients are not resistant to Plavix, maybe you can make a case where you can downgrade them from prasugrel or ticagrelor to Plavix after about a month. And then Angiomax. Again, Angiomax, we don't use it in Pakistan, but in US it's pretty commonly used. Europe uses it. And then it's been downgraded from class 1 to class 2, both for non-ST elevation MIs and STEMIs. The primary benefit of Angiomax or bivalvuloridine was that you don't really need to check your ACT. Then indication for myocardial revascularization. So I've tried to keep it really simple. One slide just for symptoms, the other one just for prognosis. For symptoms, any hemodynamically significant lesion with evidence of ischemia and causing symptoms, you can send that patient for revascularization, either percutaneous or surgical. You're totally backed by surgery. For prognosis, so left main disease more than 50%, prox LAD, 2 or 3 vessel disease with reduced EF, and then large area of ischemic burden, all are class 1A indications. Any of these, you see that, you can jump on it. Whichever way you want to intervene, we can talk about that later. But if you have undocumented ischemia, then probably try considering FFR, IFR, or some form of functional testing to document ischemia from that particular territory. So functional testing, we have discussed this. Then criteria for choice between PCI and CABG, and I think that's the bone of contention, and probably the primary aim of this talk was and is how to choose between this. So if you go by data, PCI doesn't really stand a lot of chance against CABG when you're talking about stable ischemic heart disease, because it's all driven by this one main trial, which is Syntax trial, and then we have a 5-6 year data now, all of it showing divergence of morbidity primarily driven by revascularization, not by really MIs, unless in a few, other than a few cases of complex PCI. So What do we know of syntax up till now, 5-year data? What we know is that pretty much for all groups, CABG fares better after about 5 years. But in left main with low syntax score, you're not really doing any harm to the patient by offering them a PCI, which we never thought we were allowed to offer in left main situations up till a few years ago. In diabetics, again, surgery fares better in most cohorts, but again, left main with no diabetes, you can definitely offer PCI. Now, this is just one data. We have loads of other herds of data which has been accumulated for the purpose of these guidelines. And before I go into the guideline, this is one particular slide which you need to sort of remember in your head, and that is that when the guidelines are mentioning all this data, they are also mentioning the fact that you need to consider the patient as well. Don't just calculate the syntax score and send the patient for CABG. If it's an 82-year-old frail patient in a wheelchair, it's not a patient who is going to do well with CABG. So even if they have a high syntax score, either you keep them on medical therapy or you offer them PCI. So Euroscore for them, we use STS score or Euroscore, whichever is you find easier. But you need to calculate these scores in addition to your syntax scores before you decide on what therapy these patients are going to benefit from. So for stable coronary artery disease, again, I'm just going to stick to 2 slides. One vessel CAD without proximal LAD, surgery is 2B, PCI is class 1, level of evidence will remain C. And for people who are very addicted to data and guidelines, I just want to say that 70% of cardiac guidelines are level of evidence C. So you won't find level of evidence A and B in majority of them. So take C with a pinch of salt, but accept it as long as it's class 1. With proximal LAD, both PCI and CABG are class 1. So you're not doing anything wrong by stenting a prox LAD lesion. 2 vessel CADs, again, PCI is class 1 for all 3 cohorts. So again, you can offer PCI for them. Where do things get tricky for us in terms of PCI? That is, and so just for the purpose of the talk, all I'm showing you are the slides for low surgical risk scores. Because in a high surgical risk patient, you're obviously not going to offer surgery. So we have no debate there. This is all low surgical risk scores. So low surgical risk where surgery is as safe as PCI. If even in this cohort, if you have a left main lesion with low syntax score, you can safely offer them PCI without any issues. Unless you have a left main with very tricky high syntax scores. Typically, you don't get a CTO syntax of 33 without at least one CTO of a major vessel. Usually the RCA, unless the LAD is also included. Because CERC doesn't give you a very high syntax. So they have summarized it very nicely. We have this picture up on in our cath lab, and this sort of summarizes everything that you really need to know. If you are in a fix trying to decide, this helps you a lot. Busy slide, but essentially of whatever we have talked about, things that you need to remember, low EF patients, where I see a lot of referral for low EF patients saying high risk for CABG, and they're being sent for PCI, whereas all the data actually supports use of CABG as a primary therapy for them rather than doing angioplasties in them. So coming to the ACC guidelines, I'll be quick again. So they start off with this slide, and I think Professor Suhail Saab mentioned it and Umar mentioned it. The heart team is now at the center of all American case discussions, and that not only gives you this medical legal cover, but also takes the burden of responsibility from you in case of any complication if it happens. You obviously have to do a shared decision making between anesthesia, cardiology, non-invasive cardiologist and the surgeon. They should all be involved in it. And then peri-procedurally, you have all the right team members there because they have been part of the decision making, and then that translates into better post-care. Okay, so stable ischemic heart disease. So I'm just going to highlight how similar the 2 guidelines are. For stable ischemic heart disease, if they have, remember the first slide I showed you, they have refractory angina, it's a PCI-able vessel, you do PCI, class 1 indications, same for European, same for ACC. For left main disease, if they have significant left main disease and high anatomic complexity, and if they are suitable for CABG, you go for CABG. If they're not suitable for CABG, you don't always go for CABG. You can always offer them PCI. And if they're not suitable for PCI, you don't have to intervene. Medical therapy, according to guidelines, is a very safe alternative. you're not necessarily trying to avoid a death on your table. You are actually doing the right thing by the guidelines. Then if somebody has ischemic cardiomyopathy, as I said, in the ESC guidelines, I showed you that particular slide to say if the EF is low, you go for surgery. Same is true for the ACC guidelines. So if your EF is around 50%, you can go CABG or PCI. If the EF is lower, the lower the EF goes, the higher the benefits the patient can derive from CABG. So low EF patient always think CABG. Stable ischemic symptoms, similar. So STEMI, and if it's less than 12 hours, you always go for PCI. More than 12 hours. If it's more than 24 hours, patient is asymptomatic, you don't do anything. Between 12 and 24 hours, depending on what the symptoms are, you can intervene. This is the same. This is de-escalation of antiplatelet therapy, which we showed for ESC guidelines. These are few take-home messages from ACC. Quickly, I've just highlighted the key points in red. The decision should be based on clinical evidence and not on the social circumstances of the patient. If the patient cannot afford PCI, but they are right candidates for PCI, maybe you should encourage them to go for PCI. Alternative is true for CABG. Secondly, heart team approach should be at the center of all your difficult decisions. Left main disease, surgical revasc offers long-term benefit, but PCI is a definite alternative. In stable ischemic heart disease, loads of data now shows you can get mortality benefit even if the patient is not extremely symptomatic. Surgical VASC will give them mortality benefit, but PCI is questionable, at least it will relieve symptoms. They have put, ACC has now put use of radial artery bypass as a better, higher indication than using vein grafts, so full arterial revasc. Radial artery access is recommended according to ACC, just like we had in ESC. Short duration of DAPT. We have loads of data, master DAPT trial, senior trial, and then Twilight, all suggesting if you're using the newer third generation stents, you can go on single antiplatelet after about 3 months. Stage PCI in a null culprit vessel in cardiogenic shock. Only do it if they're not in shock. Only do it if it's not very complex. If it's a complex PCI, you have done the primary lesion, get out of there. Revasc decision with diabetes should always be heart team approach based. And then in addition to your syntax score, you should always have STS or Euroscore when you're deciding between surgery and PCI. Thank you.
Thank you, Dr. Asaad, for the excellent talk. Now, Dr. Khan Shahjawan has joined us. Sir, please join us as a panelist. Now I request my next speaker, Dr. Tariq Ashraf. He is talking about treatment of non-culprit vessel in accelerated MI.